Hello, dear future nursing officers. Welcome you all to the Master Nursing classes. In the last previous session, we have discussed a lots of the important questions that is from the very important question from the all the important triads. So that including the pushing triad of the death in the emergency, and along with that we have discussed the most important Beck's triad, okay, in the cardiac temp node, and what happens to the pulse pressure, what happens to the narrow pulse pressure, wide pulse pressure, okay. So that all the thing very important we have brushed up in the yesterday's class. Along with that, we have seen some calculative portions like how to calculate the expected date of the delivery and how to calculate the GT-PAL. Okay, so along with that, we have discussed a very important question on the burn fluid calculation and where to use the modified one formula and where to use the basic formula. And until and unless examiner will not mentions the modified one, so you don't use the modified Parkland formula. So if he asked in the exam and is specifically he is mentioning that to according to the new Parkland formula or according to the modified Parkland formula, so then only use the modified one. Otherwise you can use the basic one only, and in the question you have to focus whether the exam is asking for the first 8 hours or the first 24 hours. Okay, so that is the based on that we need to calculate the result. Okay, along with that we have discussed the very important questions on the two very important skills, that is the Glasgow Coma scale, how to calculate the GCS score, and along with that I have discussed the question on the how to calculate the GCSP. So that's the very important for the Norcet exam. Okay, so along with that we have discussed the UPGAR score also in detail in perfect. Okay, so all the important thing brush up I have done in the last previous class. Okay, a very good evening to one and all who are joined to the Master Nursing classes live. So fatafat hit the like button, students, before entering to the live chat. So you can just click on the click on the like button, and yes, you have to share the class with your friends and in your WhatsApp status if possible, right? So thank you so much for trusting on the Master Nursing classes. Yes, we are trying our level best to give the completely updated content and the content which is necessary for your Norcet exam, right? So without wasting the time, we will start the today's session, okay, with this powerful motivational line. A very good evening to one and all who are attending the classes. Yes, can we start the session now? Yes, almost all you people have been joined to the session. I will start the session without wasting the time, right? So fatafat do thumbs up in the chat box whether the sound video is that everything is clear. So fatafat do thumbs up guys, fatafat. A very good evening guys. So please be on time on to the class, okay? So don't get late, right? Yes, very good. So we will start the session now. Okay, so students, the powerful motivational line of the day, it tells that many people will begin the journey, they will start the journey, okay, but victory comes to the those people who finish it in their own style and who works on that one particularly, and they will give the perfect shape at the end of the particular battle. Okay, so now your battle is on the upcoming 5 days. Okay, so you have to be in the war field to get take a batch as a warrior. Okay, yes, you have to face the very important exam, the Norcet prelims. Okay, so the very near, right? So now how you are finishing your revision going to matter to the exams. Okay, many aspirants, near lack of the nursing aspirants, they will start their preparation journey but they won't able to finish it properly, so it's difficult. Okay, so yes, you guys are the regular guys, you guys are the disciplined guys, and you guys are the motivated guys for the learning the things. So definitely yes, you are finishing this particular preparation in a perfect way. Okay, so be motivated, be disciplined. Okay, don't think about anything which is negative, right? So just think about the things which creates the positive vibes. Okay, so each other, if any one of you are reading in the library, so please take help of the each other. Okay, if your friend is having something problem in some concept, to try to explain the thing to your friend, so that is helpful for you also. Okay, so stay connected with the positive minded peoples and avoid the negative things. And with this powerful motivational lines, we will start the today's session. Okay, so try to be a best finisher, so that going to give you a best result. Okay, yes, so I hope every one of you have got your exam cities. Okay, so at the end of the video, so please mention your exam cities, right? So don't forget to mention your exam city at the end of the video in the comment box, right? So yes, let's begin the session now. Here comes to the first question. First question is here in front of you all. Okay, which of the following is the earliest clinical sign of the magnesium sulfate toxicity? The fixed question, fix one question you will get, fix one question you will get. in the prelims or in the mains. Okay, yes, very very important. So please do remember the thing. Okay, which of the following is the earliest clinical sign of the magnesium sulfate toxicity? Yes, do mention your answer in the comment box. Option A comes to the loss of the deep tendon reflex. Option B is the respiratory depression. Option C is the decreased urinary output, and option D is the cardiac arrest. Yes, what is the correct answer? Loss of the deep tendon reflex, respiratory depression, decreased urine output, and the cardiac arrest. What is the correct answer? The earliest clinical sign of the magnesium sulfate toxicity. The MgSO4, the drug of choice for the severe preeclampsia, the drug of choice for the eclampsia, the drug of choice for the very very important Torsades de Pointis or the polymorphic ventricular tachycardia. We have seen in the last previous class. Okay, the first magic session, the drug of choice for the Torsades de Pointis, I have told bacho, that is the magnesium sulfate. Right, so the drug of choice for the eclampsia, magnesium sulfate. Drug of choice for the severe preeclampsia, magnesium sulfate. Drug of choice for the pregnancy induced hypertension, labetalol. We have seen in the OBG rapid revision session, the drug of choice for the pregnancy induced hypertension is the labetalol. Right, so drug of choice for the preeclampsia, okay, the mild and moderate preeclampsia, again the drug of choice is the labetalol. Only in the severe preeclampsia, drug of choice is magnesium sulfate, and in the eclampsia, the drug of choice is the magnesium sulfate, and in the Torsades de Pointis, the drug of choice is the magnesium sulfate. Right, in the calcium toxicity, the drug of choice antidote is the, yes, again comes to the magnesium sulfate. Okay, so what is the earliest clinical sign of the magnesium sulfate? Very good of you. Okay, so almost all people given the best answer. Okay, that is the loss of the deep tendon reflex. Okay, or the hyporeflexia is the earliest clinical sign of the magnesium sulfate toxicity. Yes, Becha. So quickly we will revise the very very important things on the magnesium sulfate toxicity. Yes, one more question is there here. Okay, so try to give the answer. So I will quickly revise all the golden points on the MgSO4. Okay, so what is the minimum respiratory rate required before administering the MgSO4 safely? Okay, so you want to you want to inject the injection MgSO4, the magnesium sulfate, okay, safely. So before that one, we need to monitor for the respiratory rate. Okay, what is the minimum? What is the minimum borderline respiratory rate we required for the administration of the magnesium sulfate safely? Yes, beta. Option A 10 breaths per minute, option B 12 breaths per minute, option C 14 breaths per minute, and option D comes to the 16 breaths per minute. Beta, to administer the MgSO for the magnesium sulfate. Okay, so safely if you want to administer means at least we require, yes, almost all you people given the correct answer. So that is the 12 breaths per minute is the at least respiratory rate we require. Okay, before it is below the 12, so don't administer the MgSO4, because the MgSO4 is having the ability and potentiality to cause the respiratory depression. Yes, what are the two very important drugs which will cause the respiratory depression? One, morphine sulfate. Do remember, as a opioid, the morphine sulfate is having the ability to cause the sudden severe respiratory depression. Okay, so along with all the anesthetic drugs, all the general anesthetic drugs. Okay, along with this, yes, then very very importantly, so please do remember, MgSO4, if it is getting the toxicity, this is also having the ability to cause the respiratory depression. Okay, before that administration of the MgSO4, we need to monitor for the respiratory rate. If it is above the 12, then only we will administer. If it is below the 12, we will not administer. Yes, so what are the things we need to monitor before giving the MgSO4? Before giving the MgSO4, we need to monitor the deep tendon reflex. Deep tendon reflex is positive, then give the MgSO4. If it is negative, don't give the MgSO4. Hold the MgSO4 for the next 4 hours. Okay, so after 4 hours, again check the deep tendon reflex. If it is positive, then give. If it is negative, again hold. Okay, then along with that, we will monitor the respiratory rate. If it is above the 12 breaths per minute, give the MgSO4 injection. If it is less than 12, so hold the MgSO4 injection for the next 4 hours. Okay, so why? Because we want to prevent the respiratory depression here, right? So I need to monitor the deep tendon reflex. This is the earliest clinical sign of our MgSO4 toxicity. So please do remember all the golden words. Okay, so before administering the MgSO4, we need to monitor the urine output. Why beta? Why we need to monitor the urine output before administration of the MgSO4? Yes, injection MgSO4, it will get excretes. It will get excretes by kidney. Okay, so if urine output is more than 30 ml per hour, means it is good urine output. Okay, so whatever the injection we will administer after use, it will get eliminates normally. Okay, if it is less than 30 ml per hour, Okay, so the MgSO4 it will not eliminates from the body, and there is in the increased risk of toxicity. Okay, there is increased risk of toxicity. Right, this is the reason before giving the MgSO4 we need to monitor the urine output. Okay, one more clinical question, so very important, injection KCL. Before giving the injection KCL, we need to assess for the renal function test and again for the urine output. If RFT, renal function test, is like creatinine is high, blood urine nitrogen is high, we need to not, we will not administer injection KCL. And if the urine output is less than 30 ml per hour, okay, again don't administer the injection KCL, because this KCL also it will get expressed by the kidney. If urine output is low and you are administering the KCL, if kidney is damaged, you are administering the KCL, means KCL will get accumulates in the body. Yes, injection KCL, if it is accumulating in the body, means it will causes the cardiac dysarrhythmia. So this cardiac dysarrhythmia patient takes into the, and it will lands into the death. Okay, so before giving the injection KCL, what to monitor? We need to monitor for the urine output. Okay, if it is more than 30 ml per hour, give. If it is less than 30 ml per hour, withhold and inform to the doctor. Very important. And RFT value, creatinine is increased, blood urine nitrogen is increased, so don't give the injection KCL, inform to the doctor. Okay, so along with that before administration of the what you can say, contrast. Okay, so consider if you want to send the patient for the CECT. Okay, CECT abdomen. Okay, so CECT abdomen, or you want to send the patient for the CECT urogram, whatever the CECT. What is the CECT? This is the contrast enhanced CT scan. Okay, so here you are administering the contrast. Okay, before administering the contrast, you need to monitor for the again urine output. If it is less than 30 ml per hour, withhold. If it is more than 30 ml per hour, administer. Why? Because the contrast also it will get eliminated through the kidney. Okay, so if the kidney is damaged, you are administering the contrast, means contrast will remains in the body only, and it will cause severe allergic reactions, and it will cause us a severe skin reactions, severe respiratory problems because of the allergic reactions. Okay, so that is the reason before administering the contrast, before administering the KCL, before administering the MgSO4, you have to monitor for the output. If it is more than 30, give. If it is less than 30 ml per hour, don't give. Please do remember the concept. It is important for your exam. Yes, is that clear, bacho? Is that clear? Yes, fatafat do thumbs up. Is that clear? Well done, beta. Well done. Okay, so please do remember the things. Okay, so here comes to the very important. Urine output is more than 30 ml per hour, you can give. Okay, if it is less than 30, don't give. Why? Because we want to prevent the accumulation of the MgSO4 in the body, right? So very important, please do remember. And we will monitor the serum magnesium level. Okay, so normally serum therapeutic level will be the 4 to 7 milliequivalent per liter. Okay, so that's the very important thing. Please do consider. Okay, sorry, it's the 4 to 7 milliequivalent per liter is the normal serum concentration level, and it is the therapeutic level. Okay, so normal serum concentration level will be different. I will tell that is the one. Okay, so don't worry, in the next slide only it is there. And the antidote available for the MgSO4 is that is our calcium gluconate. We need to keep it ready at the bedside. Golden points on the MgSO4, definitely one question. Okay, fixed question for your exam, very important. And the fixed question, right? What to monitor? Deep tendon reflex need to monitor, respiratory rate need to monitor, urine output need to monitor. Okay, so before administration of the injection magnesium sulfate. Okay, hope it is clear to every one of you. Yes, here comes to the next thing on the toxicity. Okay, the toxicity of the MgSO4 and the associated related dangerous effect. Okay, so the normal range of the MgSO4 is the, yes, already I have told to you people, that is the 1.7 to the 2.4. Okay, so milligram per deciliter is the normal concentration of the our normal amount of the magnesium in the blood is the 1.7 to the 2.4 milligram per deciliter. Okay, so the therapeutic one is the 4 to 7, that is the milligram per deciliter is the therapeutic value. Okay, so and prophylaxis for the eclampsia and therapeutic value for the prevention of the seizures in the eclampsia. So we can give the normal therapeutic dose. Okay, so that is the 4 to 7 milligram per deciliter is the very important normal therapeutic dose. If it is going more than 10, so it will cause the deep tendon reflex to get lost, the earliest sign. Okay, early sign of the MgSO4 toxicity. Okay, if it is going more than 15, respiratory depression. If it is going more than 30, cardiac arrest. Very, very important. Please do remember. Okay, so cardiac arrest happens when it happens, MgSO4 is going more than 30, cardiac arrest will happen. When the respiratory depression will happen, MgSO4 is going more than 15, then the respiratory depression happens. When the deep renal reflex become absent, yes, if the deep renal reflex become absent, if the serum magnesium level is going more than 10 milligram per deciliter. Okay, so please do consider this chart. It is the very important. It is the important. Don't forget. Here comes to the next question. Yes, the question from the IMNCA, the integrated management of the neonatal and the childhood illnesses. So which of the following is not a sign of the severe dehydration in the children? Which of the following is not a sign of the severe dehydration in the children? Okay, this is also very, very important question. IMNCA question. Okay, option A, lethargic and the unconscious patient. Better in the severe dehydration, the child is altered level of consciousness will be there. The child will be lethargic and the child will be unconsciousness. Okay, so due to the lethargic and unconsciousness, so child will unable to drink the thing. Okay, so child will unable to drink the things, right? So then the very, very important. Then the option B, a skin pinch goes back very slowly. Okay, so here the skin pinch, which is we are pinching the skin and it is going back very slowly. So this is also sign of the severe dehydration. Okay, so then the option C, a very sunken eyes. Very sunken eyes also a sign of the our severe dehydration. Drinks eagerly and thirsty. This is a sign of the some dehydration. Okay, this is a sign of the some dehydration. Better according to the integrated management of the neonatal and childhood illnesses, we have the three classification of the dehydration. That is the no dehydration, some dehydration, severe dehydration. Yes, a very, very, very again very important for your exams. Okay, so no dehydration means, okay, so child will be completely active, child will be normal having eyes. Okay, so no any sunken up the eyes. Okay, drinks normally and skin pinch backs which goes back quickly. So there is no dehydration. Just we will manage in the home. Okay, so plan A, so we will encourage for the oral fluid. Okay, so then along with that, so comes to the second point, there is some dehydration. In the some dehydration, there is no any word called as the very. Okay, so very will be not there, means a very sunken eyes will be not there. Okay, very slow go back up the skin will be not there. Okay, so that is the very will come in the severe dehydration. Okay, so in the some dehydration, child will be restless, sunken eyes will be there, but in the severe dehydration, very sunken eyes. So note this one. Okay, so very sunken eyes there will be in the severe dehydration. In the some dehydration, just sunken eyes. In the severe dehydration, very sunken eyes. And drinks eagerly. Because the child is restless and having some dehydration, now the child will drink eagerly. So when you will give the glass, okay, so the child will finish the water like this. Empty, khatam, okay, tata, bye bye. So like this, okay, so drinks eagerly in the some dehydration. Severe dehydration, child will be lethargic like this, child will be unconscious. How the lethargic child and unconscious child will drink the water? No, unable to drink the water. Okay, so that is the lethargic child and unconscious child. He is unable to drink the water, so he is not drinking. Okay, and skin pinching back which is going very slowly. Better very slowly going means severe dehydration. Okay, skin pinch back which goes slowly means the some dehydration. Yes, so now tell me the very important scenario. So which dehydration state is that one? Okay, so I will give the scenario. So be attentive, be aware. Okay, and try to give the best answer. Okay, now the child is having the sunken eyes and skin pinch goes back slowly, drinks eagerly. Okay, and very importantly, child is active and alert. Child is active alert, but sunken eyes is there, drinks eagerly and skin pinch back very slowly. Is that some dehydration or a severe dehydration or the no dehydration? So what is the diagnosis? Fatafat. So do mention your answer. Is that a case of the some dehydration or severe dehydration or the no dehydration? Yes, this is a case of the some dehydration. This is a case of the some dehydration. Okay, very important. Then in this sunken eyes, I am adding the very sunken eyes. Yes, in this skin pinch back goes back slowly. I will add this is goes back very slowly. Okay, and drinks eagerly. So it is unable to drink. And active alert, instead of active alert, I will write the lethargic and unconscious. Lethargic or unconscious. Yes, lethargic and unconscious is there, and lethargic unconscious child unable to drink. Okay, so no, not drinks, and very slowly the skin is going back. Okay, so then the very sunken eyes. So these are the sign of the yes, severe dehydration. Okay, so there's a sign of the severe dehydration. Okay, so please do remember the very not drinks and lethargic and unconscious child. Okay, so that's the very severe dehydration. Okay, so according to the IMNCI, so these dehydrations they are like determined in the three color codings. One is no dehydration in the green color. Okay, so green. So that is the green color. So they can manage at the home. Okay, no problem, right? The next some dehydration in the yellow color. Yellow, dirty yellow. Okay, so do remember yellow color, right? The next one is the severe dehydration. Severe dehydration in a very important. That is in the pink color. Okay, so remember. Three color codings we have in the IMNC. One is the pink, one is the yellow, another is the green. Okay, so you have read the spelling of the fig, that is the PIG. Now I am teaching you the new pig, that is the PYG. Okay, so pink color, yellow color, green color. Beta, red color is not a part of the IMNCI. Please do consider and grasp the question in the exam. In the exam, examiner will give which of the following is not a part of the IMNCI color coding, and in the option he will give the red. So people will think red is dangerous, so we will consider for the severe dehydration. No, the pink is dangerous here, right? So red is not a part of the our IMNCA criteria. Red is the category we will consider in the disaster color coding. Okay, so I will discuss that one also. Don't worry about that. Okay, so here comes to the color coding. PYG pig, pink, yellow, green. Okay, pink andre severe dehydration, yellow andre some dehydration, and the green andre no dehydration. Okay, so yes, एनर्जी बरकरार रखना, सो मजा आना चाहिए. सेशन फुल मजा में पढ़ाना है आज, क्योंकि एग्जाम नियर है. स्ट्रेस कम करना है, मजा ही करना है पूरा. कहाँ मजा करना है? पढ़ाई में मजा करना है. ओके, सो यस, लेट्स सॉल्व द नेक्स्ट क्वेश्चन बेटा. यस, द क्वेश्चन इज वेरी सिंपल. यस, द ऑलरेडी डिस्कस्ड क्वेश्चन इन द रेस्पिरेटरी सिस्टम. आई टोल्ड यू पीपल इन डिटेल इन परफेक्ट, right? So now try to solve this question and try to give the best answer. Yes, a 3 months old infant has cough and respiratory rate of 55 per minute, but there is no chest in drawing, and no danger sign. How should this will be classified? Option A, no pneumonia. Option B, just it is a pneumonia. Option C, severe pneumonia. Option D, very severe pneumonia. Yes, I want the answer. Fatafat. Beta, in the no pneumonia, only cough will be there. In the pneumonia, cough plus fast breathing will be there. Okay, fast breathing. In the severe pneumonia, cough plus fast breathing plus chest in drawing will be there. Okay, using of the accessory muscles for the respiratory. That is the severe pneumonia. Okay, in the very severe pneumonia, cough plus fast breathing plus chest in drawing plus danger sign. In the question what they have asked, there is 55 per minute. So now I am having the problem that whether this is the fast breathing or the normal breathing, because the child age is 53 months. Okay, the child age is 3 months. Beta, for this also IMNCA given the guidelines for the fast breathing. Do remember the guidelines of the IMNCA. Okay, already I told. Okay, if the child is between the 2 months to 12 months, more than 50 breaths per minute is the fast breathing. If the child is more than 1 year, okay, so till the 5 years, the fast breathing is more than 40 breaths per minute is the fast breathing. Okay, so 0 to 2 is not a part of the IMNCA, because IMNCA is holds the a child's from the 2 months to 5 years, okay, not below the 5 months, okay, so not below the 2 months, okay, do remember. Still we need to understand, okay, fast breathing in the 0 to 2 months, that is the more than 60 breaths per minute is the fast breathing in the 0 to 2 months, okay. Now the child which came to your OPD is 3 months, which coming to the category of this particular fast breathing category, okay, and the child respiratory rate is more than 55 breaths per minute, okay. So if the child is 3 months and which is having the more than 55 breaths means, so that is the more than 50 means this is a case of the fast breathing, this is a case of the fast breathing, right? So the child is having the cough and fast breathing, so this is a case of pneumonia. So please do remember, this is a case of pneumonia. This question will strike in your exam, very again very important, okay. This is the question in your mains, okay, in your mains. This is the question which will give the rank and which will hold your name in the selection list, okay, which will make you eligible for the document verification, and it will help you to get the joining letter for your AIMS and any other exams, okay. So yes, hope it is clear to every one of you. Yes, let's quickly revise all the very important IMNC classification of the pneumonia, okay. So yes, no pneumonia means only cough is there, no pneumonia, and no fast breath, okay. So breathing and chest indrawing is not there, okay, no fast breathing, no chest indrawing, only cough is there, so that is the no pneumonia, okay. So home care we will give, fluid we will give, follow up we will tell, and we will tell about the signs of the danger sign, we will educate, and we will send the mother and baby back to the home, okay. So the next is pneumonia, okay. So pneumonia, fast breathing will be there, okay. So yes, more than 50 breaths per minute in the 2 months to the 1 year child is the fast breathing, and 1 year to the 5 year, if the breathing is more than 40 breaths per minute, that is what we call the fast breathing, okay. If the fast breathing is there along with the cough, so that is our pneumonia, okay. Or amoxicillin tablet we will give, and we will send back to the home, okay. So next, here the severe pneumonia, that is the cough will be there, fast breathing will be there, along with that chest indrawing will be there, so that is the severe pneumonia. The first dose of the injectable chloramphenicol and other antibiotic, if it is resistance to the chloramphenicol, we will give, okay. So the next is a very severe pneumonia. In the very severe pneumonia, yes, all these things, cough will be there, fast breathing will be there, chest indrawing will be there, and inability to drink, okay, inability to drink, and whatever the baby will drink, all will get vomits, and there along with that there will be a neurological signs, okay. So convulsion, chance of the seizure, okay, respiratory blockage, the stridor and the lethargy, and positive danger signs will be there, means yes, the danger signs are present, means that's the very severe pneumonia. So please do consider, here we will send the urgent referral to the higher authorities, okay. So this particular no pneumonia, it will comes under the category of the green, okay. This is a green category, and the pneumonia, it will comes under category of the very important, that is our yellow category, and the severe pneumonia, very severe pneumonia, it will comes under the category of the pink, okay. So please do remember again the fig, okay. So severe pneumonia, very severe pneumonia, pink, okay. So then the yellow is the pneumonia, and the no pneumonia is the green, okay. Hope is that clear? Yes, is that clear to every one of you? Yes. Here comes to the next question. Sam, every exam one fixed question on the SAM, okay. So last all the Norcet revised ones, there is fixed question on the SAM, whether they will question ask from the management of the severe acute malnutrition, whether they will ask the question on the criteria to diagnose the severe acute malnutrition, or whether they will ask the discharge criteria of the SAM, okay. Yes, we will diagnose, we will determine, we will identify, we will analyze it, we will give a correct answer, and we will get the good rank in the exam, okay. So according to the mid upper arm circumference cutoff of the diagnostic of the SAM, so what is the very important correct answer? What is the mid upper arm circumference? So we are using cutoff for the diagnosing the SAM. Yes, option A, 50, less than 13.5 centimeter, option B, less than 12.5 centimeter, option C, less than 11.5 centimeter, option D, less than 10.5 centimeter. What is the correct answer, beta? Yes, when we will diagnose it on the severely acute malnutrition, yes, if the mid upper arm circumference which is going less than 11.5 centimeter, means we will call this one as in the SAM, okay. So how we will assess the mid upper arm circumference? Mid upper arm circumference will be assessed, yes, mid upper arm circumference will be assessed by using the scale called as the, or the tape, what we call as this one is the Shaker step, okay. So Shaker step, Yes, very important, right? So this structure step will be used to assess the mid upper arm circumference, and this mid upper arm circumference is a age independent. Okay, it is not age dependent, it is in the age independent tool to assess malnutrition, or the age independent criteria also we can say. Okay, please do remember, very important one. It is on the age independent, it is not dependent on the age. Okay, so very important, so please do remember. Okay, next comes to the SAM criteria. Okay, so criteria of the SAM beta. So this is the very very important. Okay, so don't forget the criteria of the SAM. This one you have to write one small paper. Okay, so you have to paste your wall, and you send me one photo to my WhatsApp number or in my WhatsApp group. Okay, so I will post your particular SAM criteria in my WhatsApp, in my YouTube channel directly. Okay, so who will write NEAT, so that criteria of this severe acute malnutrition I will post in my YouTube channel directly. Okay, yes, write it properly, neatly, take a photo and send to my WhatsApp number. Okay, yes, the SAM is the severe acute malnutrition criteria. Okay, so that is the very important, so please do remember. Here the first criteria comes to the weight for the height of the zero score. Okay, weight for the height, or we can say the WHZ, that's the weight for height according to Z score, which is going less than -3 standard deviation. So that's the severely wasting child we will call. Okay, so what we call this is the severely wasting child. Okay, so that is the weight for height is less than -3 standard deviation. Okay, so then comes to the mid upper arm circumference. Okay, so the MUAC, that is the mid upper arm circumference, is less than 11.5 centimeter. Just now we have seen in the question. Okay, so then comes to the bilateral pitting edema. Okay, or the nutritional edema we can say, which is present. Okay, on the both the leg bilaterally symmetrically. So there is in the present of the bilateral pitting edema. So we call this one as in the criteria of the severe acute malnutrition. So this is our very important exam question. Okay, weight for the height according to Z score is the less than -3 standard deviation. Okay, mid upper arm circumference is the less than 11.5 centimeter, and the bilaterally there is a pitting edema due to the deficiency of the protein. Okay, malnutrition means protein deficiency, calorie deficiency. Okay, here the deficiency of the protein means deficiency of the albumin. No albumin means no oncotic pressure. No oncotic pressure means fluid will leak into the interstitial space, and the fluid is leaking in the interstitial place means, so it may causes the edema. Okay, so is that clear to everyone of you? Yes. So yes, identify the image A. Yes, identify the image A here. Is this a child of the kwashiorkor or the marasmus? Yes, what goes to the correct answer? Option A. Then the option B. Yes, two types of the malnutrition are there. One is image A, one is image B. Okay, so image B, child which is completely thin, no fat. Okay, so completely like margi it is. Okay, MAR, that is the marasmus, which is looking like margi. Okay, so do remember, this is the case of the marasmus, completely loss of the fat pad from the every part of the body. Okay, so then here comes to the option A, that is the image A. This is the case of the kwashiorkor. Okay, so this is the case of the kwashiorkor, where it is a mainly there is deficiency of the protein will be there in the kwashiorkor, and in the marasmus mainly there is deficiency of the, yes, mainly there is in the deficiency of the carbohydrate will be there. Okay, yes, in the marasmus deficiency of the calories or the deficiency of the carbohydrate will be there in the marasmus. So that is the reason a body requires energy. So body utilizes all the stored fat. Okay, and all the stored fat, stored protein, everything the body will get utilized. Okay, so then our body is utilizing the every stored fat means all the fat will get khatam. Okay, so child will looks like a very thin, very like very lean body will be there. Okay, so that is the marasmus. Okay, in the kwashiorkor there is the deficiency of the protein. Okay, protein deficiency means albumin deficiency. Albumin deficiency means, yes, albumin is deficit. Albumin is deficit means plasma oncotic pressure also deficit. Plasma oncotic pressure is reduced means the fluid will leak into the body. The fluid will leak into the body means, yes, there will be a chance of the ascites, right? The big abdomen will be there. Okay, and along with that the very important puppy face. Okay, and a very important hair colors. Okay, why? Because the for the proper color of the hair, the protein is very much necessary, right? The protein is deficit means the different hair colors will be seen in the kwashiorkor. Okay, so that is the flag hair sign will be seen. Okay, so let us discuss all the very important point. So this is the table which is very much important for you all. Okay, very important, right? So let's quickly revise the kwashiorkor and marasmus, which is very much important for your exam, right? So kwashiorkor is the, I told what is the deficient in the kwashiorkor, whether the protein or the carbohydrate. What is the deficiency? If the protein, write the P. If the carbohydrate, write the C. Yes, in the kwashiorkor, main important thing which is getting deficient is the protein or the carbohydrate. Yes, protein or energy. Which one is getting deficit in the kwashiorkor? Whether the C or the P. Yes, beta. P. That is the protein. Protein deficiency is the kwashiorkor. Okay. So it is in the severe protein deficiency with the adequate or the near adequate calorie will be there. Okay. The calories will be there. Adequate calorie or the nearly adequate calorie will be there. But there is in the severe deficiency of the protein will be there in the kwashiorkor. Okay. So protein deficit means the I told the very important plasma oncotic pressure will get decreases and the whole body edema we will see. Okay, edema will be there and the puppy face. Okay, edema of the face, the face which will looks like moon. Okay, moon shape face. The thousands time asked question in your exam. Okay, so moon shape face will be seen in case of the kwashiorkor. Okay, so then swollen belly will be there. The swollen belly, why? Because there is on the hepatomegaly will be there. Okay, so why? Because there is on the deficiency of the albumin means the important extra nutritious material which is there in the liver which will not carries out because there is on the deficiency of the albumin. Okay, so liver will be enlarged there. Okay, hepatomegaly we will see in case of the kwashiorkor. Okay, along with that there is in the deficiency of the protein. No protein means fluid will leak into the peritoneal cavity and there will be a chance of the ascites. Ascites will be there, hepatomegaly will be there. So that is the reason swollen belly or the big abdomen we will say, that one we will get in the a very important kwashiorkor. Okay, next comes to the point of the discussion. Edema, I told it is present in the kwashiorkor. Okay, and in the marasmus there is no any protein deficiency, so there is no edema in the marasmus, right? So very important. Then comes to the muscle wasting. Yes, muscle wasting will be severely muscle wasting will be seen in case of the marasmus. Why? Because in the marasmus, yes, what is getting deficiency in the marasmus? Whether the protein or the calories. So mainly there will be a deficiency of the calorie. Okay, so the mild deficiency of the protein. Okay, severe deficiency of the calorie will be there, and there will be a protein also decreases. But mainly there is deficiency of the calorie, and protein also will decreases. Do remember, marasmus means deficiency of the calorie. Okay, so or the deficiency of the carbohydrate, right? So very important, please do remember. So here the energy is not there. The source of energy is the, yes, carbohydrate is the source of energy. I am doing this much of the actions to explain the thing to you people because I have the lots of calorie in the body and it is giving to energy to me and I am very active. I am very alert. Okay, so very important here, right? So but in a case of the severe deficiency of the calories, the patient will be, yes, there will be a utilization of the extra calories from the fat and protein. The baby will start. Okay, so that is the reason entire fat will get waste, entire protein will get lost. Okay, so very important. The child will be wasted here and like emaciated looks will be there and skin and bone will be what we can say easily visible. Okay, so yes, this particular bone on the face is clearly visible. Okay, so here this side this fat, this buccal pad and this particular temporal pad of the fat is getting lost means this bone will get prominence here in a HIV patient, in a Kachagic patient. Okay, you know the Kachagic patient means entire body wasting. Okay, the loss of the fat and protein will be lost. Okay, that's what we call the Kachagic patient. Okay, so all the ribs clearly visible, right? So then the this particular bone, mandible bone, it is clearly maxillary bone, which is clearly visible. Okay, so that is the very important. We call that one the severe muscle wasting. Okay, so then the hair changes. Beta, the protein is must required. The protein is must required for the black color of the hair, right? If your hair, if it wants to be a clear and perfect black, so the protein is much and very much necessary, right? In the kwashiorkor, the protein is getting deficit. The protein is getting deficit means what happens? Yes, what happens? The hair color will be changed. Okay, so it will be like a flag. Okay, how will be the flag? So this much one color and this much another color. Okay, so this is what we call as a flag sign. Okay, reddish discoloration of the hair, and the hair, for the health of the hair, for the thickness of the hair, the protein is necessary. No protein means the hair will be thin and hair will be different color. So this is what we call it in the flag sign. What we will call this one is in the flag sign. Okay, so please do remember, hair will be thin, hair will be different color. Okay, that is what we call as in the flag sign will be seen in case of the kwashiorkor. Okay, so then comes to the thin dry hair. Okay, and but less typically discolored. Okay, so not discolored will be there in the marasmus. Okay, so then comes to the skin changes. Okay, the flaky paint dermatitis we will see in a case of the kwashiorkor. Why? Because for the proper integrity and maintenance of the skin, the protein is again necessary. The protein is deficiency means we will call this one as the flaky paint. Okay, and the dermatitis of the skin will be there. Very important. Flaky paint dermatitis of the skin and crack will be there on the skin. Okay, so the hair in the marasmus, the dry and wrinkled skin will be there. So that is the reason the face skin will be dry, face skin will be wrinkled, and the monkey like face we will see in case of the marasmus. Okay, marasmus is monkey. Marasmus is monkey. Do remember. Okay, so face appearance, moon shape in the kwashiorkor, monkey face in the marasmus. So examiner important and examiner favorite questions. Moon shape face will be seen in case of the kwashiorkor, and the monkey shape face will be seen in case of the marasmus. Is one more a moon face shape where we will study that one in the medical surgical nursing beta, where we will see the moon shape face. Yes, that is in the Cushing syndrome. Did you people study the Cushing syndrome? ಖುಷಿ ಇಂದ ಹೇಳಿ ಕಾರ್ಟಿಕೋಸ್ಟೆರಾಯ್ಡ್ಸ್ ಎಲ್ಲ ಇನ್ಕ್ರೀಸ್ ಆಗಿದೆ ಅಂತ, ರೈಟ್? So Cushing syndrome, all the corticosteroids have been increased, and very importantly, the edematous body will be there because of the excessive accumulation of the fluid. Okay, so that is the Cushing syndrome. Okay, in the Cushing syndrome also we will get the moon shaped face, and in the kwashiorkor also we will get the moon shaped face. Okay, the monkey face will be seen in case of the marasmus. Okay, so please do remember, hepatomegaly I told will be seen in case of the kwashiorkor, and in the marasmus there is no hepatomegaly. Okay, so the hepatomegaly means big liver means the swollen belly will be there. The belly will be swollen in the kwashiorkor. Okay, so there is no hepatomegaly in the marasmus. And then comes to the appetite. Okay, so here usually good appetite will be there in the marasmus. Why? Because the baby is having the deficiency in the calorie, he want to eat something and he is always craving for the food. Okay, so very high type of the food craving will be there in the marasmus. Okay, and the kwashiorkor, poor appetite. Whatever you will give to the child, he will refuse. Okay, the poor appetite will be there, and the child will be lethargic, irritated. In the kwashiorkor, in the marasmus, child will be alert, but child will be weak because of the loss of the energy. Okay, so please do remember the difference between the kwashiorkor and marasmus. Take a screenshot, revise at least 1 time, 2 time, 3 time, and try to give the best shot in the exam. Okay, so let's me quickly revise the golden points for you all. Okay, yes, the flaky paint dermatitis will be seen in which case? On hair flag. Okay, flag hair sign, flag like hair sign seen in which case? Okay, so along with that, the monkey type face, monkey face seen in which particular condition? Then after that, moon shape face, moon shape face seen in which particular condition, right? So these are the assignment question. Okay, so here comes to the next very important, more than 1,000 point important points, more than 1,000 star important points. Okay, so this is the very important management of the SAM baby, or the severe acute malnutrition management. Okay, so this is the SAM management. Okay, SAM treatment beta. So very important. Okay, this is the direct like examiner favorite concept. Okay, so like in which stage of the severe acute malnutrition we should and we must avoid the iron supplementation, whether in the stabilization phase or in the transition phase or in the rehabilitation phase, where we have to avoid the iron supplementation. Beta, the examiner favorite question. I told in the initial phase, in the stabilization phase, never ever give the iron. Okay, so no iron type will be given in the stabilization phase. Why? Because it will forms the free radicals. That free radicals will damages the internal organs. Okay, That is the reason very importantly in the stabilization phase we will not give the iron. Okay, so like this kind of the question will ask. Okay, other than that, what is the amount of the protein will be there in the F100? Okay, so the food 100 ready to use food. Okay, yes, in the ready to use food. Okay, so F100, how much protein will be there in the F100? Like this kind of the question will be asked in your exam, and only you people will be able to ask answer for this question, because I will differentiate it. I will teach you in a perfect way. I will teach you in a perfect to perfect way, so you can secure your perfect marks in the exam. Okay, so next comes to the here first page of the treatment of the our SAM is the stabilization. Okay, so in this particular case, our focus should be not to restore the all the lost protein, and not to focus on the recovering of the all the calories. Just our recovery focus will be to make the patient stable. Means electrolyte imbalance we will cover here, along with that the fluid imbalance we will cover here. That is the we will treat the dehydration, we will treat the hyponatremia, hypothermia, whatever happened. Okay, so that actual imbalance what happens, so that one we will make the patient to comes to balance, and we will stabilize the patient. Okay, so that is the focus of the stabilization phase. It will goes for the first 1 to 2 days of the severe acute malnutrition treatment. Okay, so here we will focus on the treatment of the or the prevention of the hypoglycemia, treatment of the hypothermia or the prevention of the hypothermia, prevention of the dehydration. Okay, and the prevention of the infection. These are the very important focus of the our stabilization phase. And we will give here a starter food. Okay, which food we will give here? We will give here as the starter food. Okay, in the starter food what we will give? Yep, 75 we will give. Okay, so that's the food packet which is containing the 75 kilocalorie of the our what we can say 75 kilocalorie of the energy. Okay, so in this one it is low protein. Okay, it is low protein, so that is the F75 diet which is low in the protein. That's only 0.9 gram of the protein will be there in the F75, the examiner hard favorite question. Okay, so that's the starter food will be given in the stabilization phase. Okay, and in the starter food what we will give? We will give the F75. Okay, and what is the amount of the protein in the F75? That is the 0.9 gram is the amount of the protein in the F75. Okay, and remember the golden point, should not and never ever administer the iron in the stabilization phase. Okay, stabilization phase, never ever give the iron. Okay, so very important for your exam. Okay, next comes to the transition phase. Okay, in this transition phase it will last for the duration of the 2 to 3 days. Okay, for the 2 to 3 days the duration will be there in the transition phase. Okay, so then after that, okay, so in the transition phase we will give the which food? Yes, we will give the which food in the transition phase? Yes, but a maintenance food we will give, and the food which is rich in the protein we will give. Okay, so that is the very important. Okay, so we call this one as the catch up food. Okay, what we will call this one? We will call this one as in the catch up food. Okay, catch up food we will give. In the catch up food we will give the F100. Okay, we will shift from the F75 to F100. Okay, so this is the golden point. We are shifting the child here from the F75 to the F100. So which one we will give here? In the catch up food, in the catch up food we will give the F100. Okay, so 100 kilocalorie will be there in the our very important energy, and the high protein which is there, that is the F100 which contains the 2.9 gram of the protein. Okay, so very important. Please do remember F100 is the 100 kilocalorie and 2.9 gram of the protein. So that is the catch up food. Catch up food will be given in the transition phase. Starter food will be given in the stabilization phase. In the stabilization phase, never ever give the iron in the stabilization phase. Never ever give the iron in your exam question. Okay, so very important. I am repeating the repeated time. Okay, next comes to the third phase, that is the rehabilitation phase. Okay, so here the ongoing treatment. Here we will give the ready to use food. Okay, so RUFT. Okay, so ready to use food means which is already mixed with the complete protein, complete energy which is required for the child, so that will be integrated in this one. Okay, so yes, that is the full F100 plus ready to use transition food we will give here in the feeding. Okay, so in the play therapy we will give advice, and sensory stimulation we will advise, and in the stabilization phase give iron. Okay, so iron supplementation will start from the in the stabilization phase don't give the iron, and in the rehabilitation phase give the iron. Okay, so give iron in the rehabilitation phase, the examiner question. Okay, in which phase of the our very important SAM treatment we will give the iron supplementation. Iron supplementation will be given in the rehabilitation phase, and iron supplementation will be completely contraindicated in the stabilization phase. Okay, so then after that, now the child is completely okay recovered from the malnutrition, because we have given the food, that is the F100 and ready to use food, and F75. Okay, so that along with the protein, fat, calorie, everything we have replaced here. And the most important, we need to discharge the child. When we will discharge the child, so this is your examiner question, the criteria to discharge, the discharge criteria of the SAM baby, the discharge criteria of the SAM baby. When we will discharge, if the weight for height is more than or equal to -2 standard deviation, more than or equal to -2 standard deviation, then we can discharge. If there is no edema for the last 2 weeks, okay, so in the last 2 weeks edema is subsided completely, we can discharge. And child is active and eating normally, so that is the we can discharge the child. Yes, if the child is having the normal food, send him to back home, and we will give the ready to use food, they will use that one in the home. Okay, and very importantly, there is no edema in the last 2 weeks, and there is the weight for height will be more than 2 standard deviation, so we can discharge the child. Okay, so very important. And after that, we will advise the patient to come to the recovery. We will advise the parents especially. Okay, so follow up in the next recovery period will be ongoing here. Okay, so we will advise for the follow up visits for the children, mothers. Okay, so very important, do remember all the golden words, right? So discharge criteria, do remember, and where to use the ready to use food, that is in the rehabilitation phase, and the catch up food in the transition phase, and the starter food in the stabilization phase. In the starter food, F75 will be given. In the catch up food, F100 will be given. In the F75, 0.9 gram of the protein is there, and in the F100, the 2.9 gram of the protein is there. Okay, and iron supplementation not to give in the stabilization phase, iron supplementation we can give in the rehabilitation phase. Okay, so please do remember the very important chart. Okay, so it is the examiner's hard favorite question and the examiner's hard favorite topic. Okay, so here's the next question. Which of the following is true about the physiological jaundice in the newborn? Yes, quickly revise all the physiological and pathological differentiation between the jaundice. Again, examiner's favorite question. Yes. Which of the following is true about physiological jaundice in the newborn? Option A, appears within the first 12 hours of the life. Option B, caused by the biliary atresia. Option C, peaks between the 3 to 5 days of the life. Option D, requires the immediate exchange transfusion. Better the class will go somewhat lengthy because I want to cover the yesterday's question also, today's question also, yesterday's point of discussion also, today's point of the discussion also, because I want to cover all the important question portion tables that is necessary for your exams. I want to quickly revise in front of you all, so you people can easily grasp the thing and you people can easily give the answer to the every question, right? Yes. Which of the following is the true about the physiological jaundice in the newborn? And here will be a question in front of you all, and all the options are there in front of you all. Okay, so please do comment your answer. Better exchange blood transfusion or the EBT we will give in the very important situation, that is the pathological jaundice. In the case of the pathological jaundice, we will give this one. Okay, that is, first we will give the phototherapy, then it is not requiring, means we will go for the very important exchange blood transfusion, where the entire body blood we will remove and entire body blood we will replace new one. Okay, so that will be done in the pathological jaundice, not in the physiological jaundice. Okay, so then comes to the appear within 12 hours of the life. Better if the jaundice is coming within 24 hours, that is the pathological, that is the pathological. If the jaundice is coming after the 24 hours, that is the physiological. Do remember the golden words. Okay, and very importantly, the physiological jaundice will be peak between the 3 to 5 days of the life. Okay, so 3 to 5 days of the life, the physiological jaundice will be in a peak. Okay, but the pathological jaundice will be peak at the level of the, yes, at the which level the pathological jaundice will be at the peak? It depends on the term or preterm. Let's quickly revise the difference between the physiological jaundice and the pathological jaundice. The question have been asked many times on the onset of the jaundice only. Okay, if the jaundice which is coming after 24 hours, after the 24 hours of the birth, okay, so usually on the second day or the third day of the birth, that is the physiological jaundice. Okay, if it is coming within 24 hours of the birth, okay, baby have been born and within 24 hours the jaundice have been happened, means that is the a pathological jaundice. Okay, the pathological means it is the problematic, physiological means it is the normal thing. Okay, it will happens in the all the babies, right? So very very important, please do consider the points. Okay, so within 24 hours the jaundice is happening, means there is the pathological. The very important and the golden point beta, the onset of the jaundice. Okay, and next one is the peak of the bilirubin will be there in the day 3rd to day 5th in the physiological jaundice. Okay, in the pathological jaundice, the more than 12 gram will be there in the term and the more than 15 gram will be there in the preterm, and anytime it will be get peak, anytime it will be get peak. Okay, so very important. Then the rate of the rise of the bilirubin per day beta, in the physiological per day less than 5 gram of the 5 gram per deciliter per day it will get rise in the physiological jaundice. Okay, in the pathological jaundice it will rise more than 5 gram per deciliter per day. Okay, very very important. Pathological jaundice, yes, rate of the rise of the bilirubin. Okay, so more than 5 milligram per deciliter in the pathological jaundice per day it will rises. Okay, in the physiological jaundice it is less than 5 mg per deciliter per day. Okay, so please do remember. And the duration of the jaundice, usually physiological jaundice it will get resolved within a 7 days in the term baby. In the term baby it will get resolved within a 7 days, and in the preterm baby it will resolve within a 14 days. But the pathological jaundice which persists or which continues more than 7 days in the term and which continues more than 14 days in the preterm. Okay, so that is the pathological jaundice. Physiological jaundice it will get recover in the term within 7 days and in the preterm within 14 days. But the pathological jaundice which is continuing more than 7 days in the term and the more than 14 days in the preterm. Very very important differentiation. Okay, so the next differentiation is the type of the bilirubin. Type of the bilirubin beta, in the physiological only unconjugated bilirubin will increases. Why? Because it is happening due to the immature liver, and it is happening due to the immature our liver enzyme, that is the UDPGT. Okay, so UDPGT or the UGT is deficient or the immature, so all the unconjugated one is not getting converted into the conjugated one. Okay, so that is the reason it is remaining in the blood. Okay, so the type of the bilirubin which in the pathological will increases more, both, that is the unconjugated also will increases and the conjugated will also increases. Okay, so very very important. Then comes to the appearance of the baby. The physiological it is normal only, so it is healthy and the feeding well baby will be there. The pathological well is the diseased one, so it will be a sick and the poor feeding baby will be there, and the lethargic baby will be there in the pathological jaundice. Okay, so next comes to the point of the discussion. There is the cause of the our physiological jaundice. I told that is the immature liver enzymes, especially UDPGT. Okay, and the most common cause of the pathological jaundice, that is our RH incompatibility is the most common cause for the pathological jaundice. So this is the examiner favorite topic, favorite question. The most common cause for the pathological jaundice is the, yes, that is our RH incompatibility. Okay, most common cause. And it also happens due to the sepsis in the baby, G6PD deficiency in the baby, that is the hemolysis in the baby, and the hypothyroidism in the baby, and AB incompatibility in the baby. Okay, wherever there is in the more blood is getting break, there are the situation where the bilirubin will excessively produces. Okay, so especially most common cause for the our pathological jaundice is the RH incompatibility. Okay, so please do remember, right? So the next is the Kramer rules. So very very important. Already asked a question in the Norcet 4. Yes, the Norcet 4 favorite examiner favorite question. Already asked in the Norcet 4. Kramer rules. For estimation of the bilirubin in the baby. Yes, this is the photo which came in your WhatsApp channel. Okay, so yes, if the face and neck is getting the yellow color, if the face and neck is getting the yellow color, only face and only neck is in the yellow color, we will say the blood bilirubin level will be 4 mg per deciliter, right? If the upper chest and upper abdomen is getting yellow color, let me write it in the yellow only, so you will be easily you can understand the thing. Okay, we have the yellow color also here. Yes, if the face and neck is yellow color, so that is the 5 milligram per deciliter will be the amount of the bilirubin which is there in the blood. Okay, so then the next one is the, if upper abdomen and the chest, if it is yellow in color, so the chest and the upper abdomen, which is yellow color, means the expected amount of the bilirubin in the blood will be the more than 10 milligram per deciliter, right? So if in case the and the upper thigh, okay, upper thigh and lower abdomen, which is yellow in color, means, or yellow discoloration, means, so that's the very important. Lower abdomen and upper thigh and lower abdomen yellow in color, means, so that's the amount of the bilirubin will be, yes, amount of the bilirubin will be 12 milligram per deciliter. Okay, so this is the amount of the bilirubin, very important, do remember. If in case lower leg, both side, okay, so not palm and sole, okay, so lower leg and this particular hand, okay, so arm and lower leg, if it is yellow color, means that is the 15 milligram per deciliter. Okay, so very important. If it involves the palm and sole, okay, so palm is involved and the soles are involved, palm and soles are yellow color, means the bilirubin have been went more than 15 gram per deciliter, so that is the 18 to 20 milligram per deciliter will be the bilirubin if the palm and sole went more than 18 to 20 milligram per deciliter. So this is the Kramer's rule, a very important examiner favorite question, beta. So many time it was asked in the previous exams. Okay, so hope it is clear to everyone of you. Okay, so don't forget this particular Kramer's rule, okay, in the estimation of the bilirubin based on the body color. Okay, so hope it is clear to everyone of you. Yes, it is looking like early data filler, but it will give the marks in the exam. Okay, right, so here will be the next question. Yes, next question is very simple. What age are the first dose of the pentavalent vaccine? That is the DPT, Hib and Hub will be administered under the national immunization schedule. So first tell me, what is the pentavalent vaccine? Pentavalent means, penta means 5, okay, which is composition of the 5 vaccines. Okay, so what are the 5 vaccines we have here? So that is the diphtheria, pertussis, tetanus, hepatitis B and the Haemophilus influenza type B. Okay, so these are the total 5 vaccines we have in the pentavalent vaccine. So many times they have asked the composition of the penta only in the exam. Okay, so don't forget diphtheria, pertussis, tetanus, hepatitis B, that is the hep and Hib. Okay, so that is the Hib and Hub. Okay, so please do remember hepatitis B, Haemophilus influenza B, DPT, that is the diphtheria, pertussis and the tetanus. Okay, so total 5 diseases against it is protecting. So I call this one as in the pentavalent. Okay, so the 5 valent. Okay, so very important, please do remember this pentavalent composition. Okay, so is that clear, sir? Next, so whenever we will what are the schedule where we will administer the pentavalent vaccine in the national immunization schedule? Yes, can we give it is in the birth? No, beta, birth we will not give the pentavalent vaccine. So in the birth we will give the 3 vaccines, that is on the oral polio vaccine, hepatitis B vaccine and the BCG vaccine. Okay, so on the birth we will give the birth dose of the or we can say 0 dose of the OPV. Okay, and along with that on the birth we will give the birth dose of the hepatitis B and BCG vaccine we will give at birth. Okay, so option A is not going to be a correct answer. Why? Because at birth we will not give the our pentavalent vaccine. So I am eliminating the option B. Then comes to the 6 week, 10 week, 14 week. Yes, almost all you people given the correct answer. The schedule of the pentavalent vaccine will be the 6 week, 10 week and 14 week, right? So this is the correct answer. And the 9 week 9 month and 16 to 14 months, here will be the booster dose which will go. So I will discuss in detail that you will come to the all the conclusion and you will come to the all the clarification. So for this particular question, answer B goes to the correct answer. Okay, so answer B goes to the correct answer for this particular question. Very important, right? So here comes to the all the explanation about the national immunization schedule and the thing which I am explaining now, which is very much important for you all. Okay, so next is the birth. At birth, what are the vaccine we will give? Okay, so do remember BOH. Okay, so that is the BOH is the B is the BCG, O is the oral polio vaccine, and the H is the hepatitis B. Okay, so BOH. Okay, so please do remember at the birth BOH. Okay, so we are giving the BOH in the birth. Okay, at the birth BOH, that is the BCG vaccine. At the birth we are giving. Okay, so till what time we can give? we will give till up to 1 year. Okay, so if you are giving less than 1 month, in the less than 1 month you are giving means, so you can give the 0.05 ml of BCG vaccine, that is by the intradermal route, okay, in the left upper arm. If you are giving it is less than 1 month age baby, okay, so that is the 0.05 ml BCG vaccine intradermal route we will give. Okay, so if you are giving more than 1 month, okay, till the 1 year, the dose of the BCG vaccine is the 0.1 ml. Okay, same intradermal route. Okay, so again the very important thing, please do remember, more than 1 month till the 1 year we are giving the BCG vaccine, that is the 0.1 ml is the dose. If we are giving less than 1 month, so that is the 0.5 ml will be the dose. Okay, so route remains same, intradermal, and the site remains same, that is the left upper arm. Okay, so please do remember this particular dose of the BCG vaccine, because it will comes in your exam directly, and many time asked exam already in the previous questions. Okay, so hope it is clear to everyone of you. Right, here comes to the next vaccine we have here is the, that's hepatitis B vaccine. Okay, we are giving this one to protect against the hepatitis B vaccine, and the BCG will be given to protect against the severe form of the TB. Okay, to protect against the severe form of tuberculosis we want to protect. Okay, and extrapulmonary TB against also we want to protect, so then we are giving the BCG vaccine. Okay, so then the hepatitis B vaccine birth dose will be given within 24 hours. Your examiner favorite question, and your examiner lal question, your examiner red question, the repeatedly asked question. Okay, so that's the hepatitis B vaccine we should be given within 24 hours after the birth. Okay, so if you are giving after 24 hours, there is no use, only. Okay, so you are giving the hepatitis B vaccine within 24 hours of the birth, so there will be a use will be there. Okay, you are giving after 24 hours of the birth, there is no use of the hepatitis B vaccine. Okay, so please do remember the very important thing. Okay, so next comes to the dose of the hepatitis B vaccine, 0.5 ml will be the dose of the hepatitis B vaccine, and we will give this one is the intramuscular route. Okay, intramuscular route, where we will give the best IM site in the neonates. Yes, best IM site in the neonate is the, yes, that's the vastus lateralis, or the what we can say the left side mid thigh, that's the anterolateral aspect of the mid thigh we can say. Okay, so anterolateral aspect of the mid thigh will be the site. Okay, so this is the site, and the muscle is the vastus lateralis muscle. Okay, so name of the muscle where we will give the injection in the newborn is the vastus lateralis is the muscle name. Okay, vastus lateralis is the muscle name where we will give the injection in the newborns, especially the IM injections, or the site is the mid thigh of, that is the anterolateral aspect of the mid thigh. Okay, so very important, please do remember. Next comes to the oral polio vaccine dose number 0. Okay, so OPV 0 dose we will give within 15 days. The examiner favorite question, within how many days we need to give the birth dose of the oral polio vaccine? So oral polio vaccine birth dose should be given within 15 days. Okay, so within 15 days, very important. How we will give the oral route? The word itself is telling it is on the oral polio vaccine. Okay, what is the another name of the oral polio vaccine? Whether this is a Sabin or Salk? Yes, tell me in the comment box. The oral polio vaccine another name, whether it is Sabin or the Salk. Yes, guys, फटाफट do mention your answer in the comment box. Oral polio vaccine, whether it is the Salk vaccine or the Sabin vaccine. Yes, the oral polio vaccine is the Sabin. Okay, it is in the Sabin. Salk is the another name of the IPV. Okay, not OPV. Because OPV we call it as Sabin. IPV we will call that one as the Salk vaccine. Okay, so dose of the oral polio vaccine will be the 2 drops. Okay, and oral route we will give. Okay, so that is the 0 dose given within 15 days. Hepatitis B first dose or the birth dose will be given within 24 hours. BCG we can give until the 1 year, but the dose changes here. You are giving within 1 month, so 0.05 ml BCG vaccine intradermal route. If you are giving after the 1 month till the 1 year, there is the 0.1 ml intradermal route. So please do remember, the site of injection and the best and the safest site of the intramuscular injection in the newborn is the anterolateral aspect of the mid thigh, and the which muscle we will give the injection, that is the vastus lateralis muscle is the muscle where we will give the injection. Okay, so where it is very much clear to everyone of you. Okay, so here comes the next immunization schedule, vaccines where we will give at the 6th, 10th and 14th week. Beta So penta we are giving the 6, 10 and 14. OPV we are giving the 6, 10 and 14. Rota we are giving the 6, 10 and 14. But IPV we will give 6 and the 14. 10 no IPV. PCV we will give 6 direct, 14. 10 no PCV. Yes, which all are the following vaccine we can give at the 6, 10 and 14 weeks except one. Okay, so option A is the penta, option B is the oral polio vaccine, option C is the FIPV. Okay, that is the fractional IPV. Then the option D is the rota. Yes, so which one is the correct answer? Beta pentavalent vaccine we are giving at the schedule of the 6-week first dose, and the second dose at the 10-week, and the third dose at the 14-week, right? So with a 4-week gap we are giving. Okay, or we can say very important 4-week means 1 month gap. Okay, so we are giving the very important penta, we are giving 6, 10, 14. Then the OPV also, a birth dose will be given at the or the OPV 0 dose will be given at the birth. Okay, and the OPV first dose will be given at the 6th week of the life. Your examiner's favorite question. Better in the exam the question will come, the oral polio vaccine first dose will be given at, oral polio vaccine OPV first dose will be given at the option A only. They will give the birth. He will mention the answer as the birth, and it will land you into the negative marks. They are asking the question where we will give the first dose of the OPV. We will give the first dose of the OPV at the 6th week of the life. Sir, just now only you told in the birth we will give the OPD. Beta, that is the OPV 0 dose. It is not first dose. The OPV 0 dose will be given at the birth. OPV first dose will be given at the 6th week. Is that clear? Clear. Okay, next comes to the point of the discussion. Okay, so OPV second dose again the 10-week, and OPV third dose at the 14-week of the gestation. The dose will be again, I have told already, 2 drops oral. Okay, so at the respective weeks with the 1 month gap we will give. Okay, so next the fractional IPV, it will be given at the 6th week first dose. First dose will be given at the 6th week, and the next second dose will be given at the 14th week. Okay, 14th week. So the gap in between will be the 8 week, or the gap in between will be the 2 months. So please do remember, right? At the 10 week we are not giving the IPV, so the correct answer will goes to the fractional IPV will not be given at the 10 week. Okay, so that's the very important, right? So along with that, remember the PCV, that's the pneumococcal conjugated vaccine. Okay, so pneumococcal conjugated vaccine also we are not giving at the 10 week. We are giving it first dose at the 6th week and the 14 week second dose. Okay, so IPV, the fractional IPV we are giving now. Okay, that's the intradermal route, the 0.1 ml at the right upper arm. Okay, the first dose will be 6 week and the second dose will be 14 week. And in the intensified mission Indradhanush 5.0, the third dose of the fractional IPV added. Okay, so that is at the 9 month of the after birth. Okay, so do remember the fractional IPV third dose also added. The first dose at the 6th week, second dose at the 14th week, third dose at the 9th week. Okay, so please do remember in which this one it is added. It is added in the intensified mission Indradhanush 5.0. So the third dose of the fractional IPV added in our national immunization schedule. That is at the 9th month of the week. After the birth. Okay, so please do remember previously there is the only IPV, that is not fractional IPV, that was we are giving by the IM route. Okay, now in the national immunization schedule we are giving the fractional IPV. Okay, so that is the 0.1 ml intradermal. But previously we were giving only IPV, that is the 0.5 ml, that was the intramuscular route, old one, and now new one which was included in the national immunization schedule is the fractional IPV. Cut made in the IPV. Okay, so that is the fractional IPV. We are giving little only 0.1 ml only we are giving. That is the not by the IM route. We are giving that one by the intradermal route, and the site will be the upper arm. Okay, so there is the right upper arm will be the very important site of the administration of the IPV. Okay, so please do remember. So the next one is the pneumococcal conjugated vaccines. So that is first dose we are giving at the 6, 14 dose we are giving at the 14. the second dose we are giving at the 14, and the I will tell about the booster dose also. Okay, don't worry. Yes, now tell me, this particular pneumococcal conjugated vaccine will be given against protection of the which of the particular disease? Yes, against which disease we are giving the PCV? That is the conjugated vaccine, pneumococcal conjugated vaccine. Yes, against which disease we are giving the pneumococcal conjugated vaccine? So please do mention your answer for still lots of the updates we need to study on the immunization schedule that is there pending. Okay, right? Yes. So PCV will be given against the pneumonia. Yes. So that is the pneumococcal conjugated vaccine will be given against the pneumonia. Okay. So now tell me, that is the fractional IPV will be given against the which disease? Fractional IPV will be given against which disease? That is, yes, against the polio vaccine, polio disease. Okay. So the next one is the rotavirus vaccine. Yes. Rotavirus vaccine will be given against which of the following disease? Option A, pneumonia. Option B, polio. Option C, rota disease. Option D, diarrhea. Tell me the answer. Rotavirus vaccine will be given against which of the following disease? खिलाड़ी है तुम लोग. Okay, so that is the correct answer. The diarrhea goes to the correct answer. So rotavirus vaccine will be given against the diarrhea. Okay, so most common cause of the diarrhea in the children is the rotavirus. Okay, in order to protect against the rotavirus, we are giving the rotavirus vaccine. Okay, so on the rotavirus vaccine, there is an update is there in the thing I will tell. Okay, so on the old rotavirus vaccine, okay, vaccine while monitor related updates will be there. I will tell. Okay, don't worry. I will finish all the updates before your exams. It is my responsibility. You people don't have to worry about that one. Okay. Yes, the OP will be given against the polio and the pentavalent, protect against the 5 diseases I told: diphtheria, pertussis, tetanus, hepatitis B, and the Haemophilus influenza type B. Okay. So this is the very important thing. So just we have discussed here now. Okay. So next here comes to the 9 months to the 12 months. Okay. Yes, the MR. Previously we were giving the measles, mumps, rubella. Okay, so now we are giving the MR only. Okay, so that's the measles and rubella. Mumps is not giving. Okay, so that is the MR means measles, rubella. First dose will be given at the 9 month of the age of the baby. Okay, so first dose of the MR will be given at the 9 month. Okay, so the MR vaccine is the vaccine which we will give in the subcutaneous route. Okay, so which route? Please remember, whatever the thing, just till now we have studied the penta, IM route, oral polio, oral route, okay, and this one BCG and the fractional IPV, intradermal route, and no vaccine we studied till now by subcutaneous route. Now we are studying the first vaccine, that is the MR vaccine, subcutaneous route, and one more new one, that is the old one, that is the live vaccine of this JE we are giving through the subcutaneous route. Okay, so the killed one we are giving the again IM one. Okay, so now we are using the killed JE again, that is also we are giving by the IM route. Okay, so the first vaccine which was there in the immunization schedule, which is with the subcutaneous route, was the MR vaccine. Okay, yes, the measles and the rubella vaccine. Okay, measles rubella vaccine, that is a 0.5 ml. We will give this one by the subcutaneous route. Okay, so at the right upper arm we will give the vaccine. Okay, so very important. Then comes to the PCV. Okay, pneumococcal conjugated vaccine booster, we will give the again 0.5 ml intramuscular route, that is the right mid thigh. Okay, so next comes to the JE. Okay, Japanese encephalitis vaccine. In the Japanese encephalitis vaccine, we are giving that one live attenuated vaccine, that is the 0.5 ml subcutaneous route at the left upper arm. So this one is the old one. Okay, so this one is the old one. Now in the intensified mission Indradhanush, okay, 5.0, there is in the killed JE vaccine is added. So that one we are giving the 0.5 ml intramuscular route, that is the mid thigh. Okay, so now the killed JE will be added in the very important our national immunization schedule. Okay, so please do remember the killed also. Okay, so live we are giving the subcutaneous route and the killed we are giving the IM route. Okay, so this is our very important differentiating point. Okay, live JV will be given by the intramuscular route, and the killed JV will be given by the intramuscular route, and the live JV will be Japanese encephalitis vaccine will be given by the our subcutaneous route. So please do remember. Then comes to the vitamin A prophylaxis. Okay, in the national immunization schedule, vitamin A prophylaxis also will be included. The first dose, how much we will give? That's the 1 ml of the syrup, or the 1 lakh international units orally we will give the vitamin A syrup. Okay, syrup vitamin A. So that is the first dose will be the 1 lakh international unit. Total 9 mega dose we will give. Okay. So total how many mega doses of the vitamin A we will give? Total 9 mega doses. Okay. Among the 9 mega doses, the first dose of the vitamin A is the 1 lakh international unit is the first dose of the vitamin A, and the second dose, third dose, fourth, fifth, sixth, seventh, eighth, ninth mega dose we will give. Okay, so from the second dose onwards, the dose will be the 2 lakh international unit we will give. Okay, so how much should be the gap between the each dose? How much should be the gap between the each dose? The gap between the each dose will be the 6 month. Okay, so 6 month gap should be maintained. Okay, the first dose will be given at the 9 month. Okay, so next dose will be, yes, with the 6 month gap we will give. Okay, so please do remember, total 9 mega doses we will give. Okay, first dose is the 1 lakh international unit, that is the 1 ml. Okay, that is the 1 ml, and the 2 lakh international units, so that is the measures about the 2 ml. Okay, so here the again 2 lakh, we will give till the till 9th dose we will give them a 2 lakh international unit only. Okay, so 2 lakh international unit we will give till the 9th dose. Okay, so total how much international unit of the vitamin A we are giving? So that is the 1 lakh is the first dose, and the remaining 8 is the, yes, remaining 8 is the 2 lakh. Okay, so total 16 plus 1 is the 17 international unit of the our vitamin A we are giving in the total 9 mega doses. Okay, 9 mega doses we are giving the 17 international unit of the vitamin A. Okay, so please do remember, very important. Okay, hope it is clear. The gap you have to remember. Okay, there is the 6 month gap should be there between the each doses. Okay, so the next is the a very important one, vitamin A first dose is the 1 ml or the 1 lakh international unit orally we are giving. And I told in the intensified mission Indradenius 5.0, okay, intensified mission Indradenius 5.0, the fractional IPV third dose is added. Okay, so this was the update for you all. The third dose of the fractional IPV which was added in the mission intensified Indradenius 5.0. Okay, so if IPV will be added to the, will be given at the 9 months to the 12 months in between, anywhere we can give. Okay, so very important, please do remember. Okay, so here comes to the vaccines which are given at the 16 to 24 months. Okay, so MR2 we will give MR2 16 to 24 months, again by the subcutaneous route 0.5 ml right upper arm, same site. Okay, so then the DPT booster, okay, DPT booster we will give 0.5 ml, again intramuscular route left mid thigh. Okay, so then the OPV booster 2 drops oral, and the JE if applicable means wherever there is the endemic area. Okay, this is the subnational disease. Okay, some area which is having the abundant JE, and in the some area it is nowhere it is there. Okay, wherever it is the pandemic, there we will, sorry, wherever it is the endemic means which is confined to the specific area, then only we will give the JE, otherwise no need of this JE vaccine. Okay, but it is there in the national immunization schedule, it is there. Okay, so same as the JE1 site and route. Okay, so that is the JE killed one. How we are giving the JE killed one? Yes, JE killed one we are giving by the IM route, and the JV live one we are giving by the subcutaneous route. So if you are having the killed vaccine, give by the 0.5 ml IM, and if you are having the killed vaccine, so give it by the 0.5 ml IM, and if you are having the live, oh, that is the 0.5 ml subcutaneous. Okay, so that is the very important, right? So next comes to the in the 16 to 24 months. Okay, so I told you it is the second dose to the 9th dose of the vitamin A. Okay, total 2 ml or the 2 international unit, 2 lakh international unit of the vitamin A is giving. Okay, with a 6 month of the gap. Okay, every 6 months we are giving till the 5 years orally we are giving total 9 mega doses or the 17 lakh international unit of the vitamin A we are giving. Okay, so that is the very important for your exams. Okay, so lots of the golden points we are revising, not only 1 and 2. Lots of golden points. Okay, at the 5 to 6 year, so we are again DPT booster dose we are revising. Okay, DPT booster dose number 2. Okay, booster 1 we have given in between the 16 to 24. Okay, so DPT booster dose number 2 we will give at the very important 5 to 6 year. Then a 10 to 16 year TD, there is the tetanus and diphtheria will be given at the 10 to 16 year. There is same 0.5 ml intramuscular IM That is the upper arm we are giving. Upper arm we are giving. Okay. And for the pregnant woman, very, very important. Examiner favorite question. Previously we were giving the TT injection. Now we are giving the TD. That is the tetanus and the diphtheria. Okay. So previously we were giving only TT. Now we are giving the TD. Okay. So TD, T means tetanus, and the small d means the small amount of the diphtheria. TD1 we will give early in the pregnancy as soon as possible. Mother comes to the OPD to register her pregnancy. We will give early in the pregnancy TD1. Okay, so that is the 0.5 ml intramuscular in the upper arm. We will give the TD1. Okay, so then the TD2 with the 4 weeks gap or the 1 month gap between the TD1. Okay, TD1 today I given means after 1 month I will give the TD2. Okay, so again same 0.5 ml. Intramuscular route, upper arm will be the site. Okay, so then the TD booster, beta in the pregnant woman. Okay, so remember this concept. Based on the previous pregnancy history, we will give the TD booster. Okay, not we will directly inject the TD booster. Okay, so previous pregnancy she has taken the TD1 and TD2 both she have taken, and within 3 years again she got pregnant. So in the current pregnancy, we will give only TD booster. We will give TD1, TD2 not necessary if she is getting pregnant within 3 years after the first vaccination. Okay, so first in the first pregnancy she have taken the TD1, TD2 both she have taken. Okay, within 3 years again she get pregnant, only TD booster we will give. Okay, and in the previous pregnancy she have taken TD1 and TD2, and second pregnancy happened after 3 years. Again same dose we will repeat, TD1 and TD2 both we need to give if she is pregnant after 3 years. Okay, and there is no TD vaccine in the previous pregnancy. She have not taken TD1 also, TD2 also. Okay, so any duration irrespective of the time, if she is second time getting pregnancy means TD1, TD2 we will give if she is not taken the any TD vaccine in the previous pregnancy. Okay, this is the very, very important concept beta. I have simplified as my level best to explain you people. Okay, so lots of the creativity and somewhat minimum creativity I have planned to make it possible to easily explain to you people. Okay, so yes, lots of the effort is there, and which requires only one like from you all and one share from you all. Okay, so if it is really helping you all, so don't hesitate to share in your WhatsApp groups, and don't hesitate to hit the like button. Okay, your one like, it will give lots of the confidence and energy to us. Okay, so yes, hope entire immunization schedule we have discussed. Okay, with very rapid and perfect explanation. Okay, so here will be the next question is in front of you. Yes, what is the purpose of the performing the shake test? What is the purpose of the performing the shake test on the vaccines? Your Norcet question. What is the purpose of the performing the shake test in the very, very important on the vaccines? Okay, this is a very important question, beta. Right? So to check the potency of the vaccine, option A, option B, to detect the freeze damage in a freeze sensitive vaccines like DPT and TT. Option C is the to verify the expiry date of the vaccine, and option D is the to manage the pH of the vaccine. So what is the correct answer? Why we have to perform the shake test? Yes, beta. Option A, option B, option C, option D is in front of you all. So what is the correct answer? I want everybody's response in the comment box. Yes, to check the potency of the vaccines, to check the or to detect the freeze damage in the freeze sensitive vaccines like a DPT and TT. Yes, almost all people given the correct answer. That is the to detect the freeze damage or the freeze sensitive vaccines like DPT and TT. So we need to do the shake test. What we will do in the shake test? Nothing we will do. We will just shake it. Okay, shake it, Pushpavati. Did you heard the song like that? We will shake the vial. Okay, so we will take the freeze sensitive vial. Okay, and along with that there will be a control vial will be there. Okay, so just for the comparison purpose we will keep one control vial. Okay, and one test vial will be there. Okay, so what we will do in the shake test, it is used for the freeze sensitive vaccines. Okay, like DPT, hepatitis B, Penta, PCV. These are the freeze sensitive vaccines. Okay, so in this particular freeze sensitive vaccines, okay, so we are checking the whether these are the ready to use, or whether we can use this one, or whether we need to discard this one. Okay, so yes, if we are how we will do that one? By the shake test. Okay, so in the shake test what we are doing, shake the vial and compare with the freeze destroyed control vial. Okay, so this just we are shaking the vial, and I am comparing this one with the control vial. Okay, so look at this one. So this test vial, okay, so just I have shaked completely. so which is looking very clear, and all the powder form or the amorphous which is deposited in the or the sedimented in the down of the bottle only. Okay, this is a vaccine bottle. Okay, even after shaking the vial, okay, all the powder form or the amorphous form or the crystal which is sedimenting in the down only, means it is not mixing properly. So this is a vial, we can discard it, this one. Okay, we discard the vial. Okay, don't use the vial, right? So after the shaking, it is clear liquid. It is clear liquid, means discard it. Don't use this, right? So after the shaking, okay, after the shaking, we will comparing with the control vial. So vial which is completely mixed with the amorphous. Okay, amorphous is not sedimented down in the bottom of the bottle. Okay, so it is completely mixed. Okay, so this is the test vial is completely mixed. We can use this one. Okay, so if it is completely mixed, okay, white amorphous which is looking like, use that one. Okay, so if it is clear liquid, don't use that one. If it is white amorphous, use that one. So this is the shake test. Okay, it will be very important for your, yes, for your upcoming exam. So don't just neglect the thing. This is the very important thing I am telling to you people. Okay, so don't neglect it, right? So clear liquid, discard it. White amorphous liquid, use it. Okay, so look at this one, the star mark, which is don't use. You are shaking, still the vial is clear, the not mixing properly, discard it. Okay, and you are mixing and which is completely mixed the amorphous, so you can use that one. Okay, so this is what you call the shake test, right? So hope it is very much clear to every one of you, right? In the tomorrow session, again we will discuss and deal with the more important, and especially I will discuss the all the updates on the internship and mission Indradhanush. Okay, so don't miss any single particular class, because in the simple classes and in the small classes I am covering the huge syllabus which is required and necessary for your upcoming exam. Okay, so yes, I hope the whatever the content we have studied with today, which is the best content what I have given from the my side. And again I am requesting while are preparing for the Norcet 9 exam, okay, so don't forget to give the real time exam. Okay, don't forget to give the real time exam, so it will help you to manage the time, because in the 18 minutes we have the 20 questions, that is the 0.8 second 0.8, like we are not getting even a full minute also. Okay, so we are getting only 0.8 minutes to solve the one question. Okay, so that is the very important thing, just to try to understand. Okay, so give the real time exam, whether sir it is free or paid. Beta, it is completely free. Sir, where we will get this one? Okay, you will get this one in the Master Nursing Classes app. Okay, so you will get this one in the Master Nursing Classes app. Okay, so that is the very important one, right? So where will we get this Master Nursing Classes app? Okay, so for the Android users, the link I have given in the description box, and for the iOS users also I will mention the link in the description box. Okay, first iOS user need to download the My Institute app. Okay, My Institute app. Okay, that is red in color. Okay, so in that one the org code you have to add is the LOW and NYL. Okay, so this is the org code to get access for the Master Nursing Classes in the iOS user or the iPhone user, what you can say, that is the iOS user. So you can download the My Institute app and use the org code, that is the low nil. Okay, so then for the Android user, just go for the playlist Play Store, just type the Master Nursing Classes app, you will get it. Okay, and if you want to access it in the like computer also or in the laptop also, if you want to experience the real time exam, you can directly type the Master Nursing Classes website. Okay, you can log in with the same mobile number and you can give the test. Okay, so both for the laptop, computers, iOS and all the Android mobiles, everything it is available. Okay, so which is free of cost. Utilize it before the exam and get the best rank in the upcoming mains exam and the prelims exam as well. Okay, so yes, thank you so much for watching the video till the end. And at the end, only one request: don't forget to share the class with your friends. Okay, and don't forget to keep the class in your WhatsApp status. And if you found the content is helpful, so please hit the like button. And whatever the assignment I have given in the today's class, okay, so that's the flag hair sign will be seen in which condition, monkey face will be seen in which condition, and the moon shape face will be seen in which condition. Okay, try to mention the answer to these final and the assignment questions in the comment box. Thank you so much for watching the class till the end. Jai Hind, Jai Bharat. We will meet again with the same energy and more energy in the next class. Tab tak ke liye, Jai Hind, Jai Bharat. Take care. Love you all. Bye bye.